Yes, we can start.
Good morning, all. Today, I will be presenting a seminar on evaluation of sudden loss of vision. So, diminution of vision can be transient, that is, vision returns to normal within 24 hours, usually within 1 hour, or it can last more than 24 hours. The vision loss which lasts more than 24 hours can be either sudden or gradual, and both can be either painless or painful. So, this is just a general map of approach of how to, go about handling such patients. So whenever a patient vision loss comes, first we can basic test we can do is confrontational visual field. Then if there is a monocular field defect, then mostly the anterior visual pathway can be involved. And if there is a binocular field defect, then the posterior visual pathway is involved. If binocular field defect is there, then according to the pattern of field loss, whether it is homonymous or bitemporal, we can localize the lesion to either post-chiasmal or chiasmal. Then, if it is a monocular field defect, then with normal visual acuity, then we have to suspect that the lesion is somewhere in the peripheral retina. And if the central visual acuity is affected, we have to conduct a pinhole test. In pinhole, if the visual acuity is normal, then mostly the cause of loss of vision is a refractive error. If it is reduced on pinhole, then we can perform the swinging flashlight test to detect the RAPD. If RAPD is absent, then we can do a funduscopy, and if the view is clear, then the lesion is mostly on the macula. And if the view is hazy, then it is either the media opacity in the form of either corneal opacity or cataract, or vitreous opacity in the form of vitreous hemorrhage. And if RAPD is present, again in fundoscopy, if there is any abnormal retinal presence, then the lesion is in the retina. And if it is a normal retinal presence, then the lesion is in the optic nerve. So the loss of vision, again, it can be painful or painless. If it is painless, it can be sudden or gradual. And the DDs in sudden are, if it is total loss of vision, then it is central retinal artery occlusion. If it is generally partial loss of vision, incomplete or partial retinal detachment can be the lesion. Then if in painless gradual, cause can be central retinal venous occlusion. Then in painful, again, if IOP is increased, then it can be glaucoma. If IOP is normal, it can be optic neuritis. And if it is painful associated with temporal headache with increased DSR, the cause can be giant cell arteritis or temporal arteritis. So DDs of sudden loss of vision, again, in sudden painless and sudden painful, as I've mentioned. So first we will discuss, that is CRAO. Central retinal artery is the first branch of ophthalmic artery, which supplies the nerve fibers in the optic nerve as well as inner layers of retina. In addition, there is cilioretinal artery, which is a branch of short posterior ciliary artery, separate branch of ophthalmic artery. Blockage of may be caused by either emboli, vasculitis, or spasms, and the occlusion of ophthalmic artery due to giant cell arteritis, while occlusion of cilioretinal artery may be secondary to CRVO due to increased outflow resistance. The patients with CRAO generally complain of visual loss over the entire field of vision, while those of BRAO complain hemifield defect. Patient can also have amaurosis fugax. The patient with cilioretinal artery generally has central sparing lesion, so it is can have 20/20 vision. Complete loss of vision to no light perception should raise suspicion of ophthalmic artery occlusion. In CRAO, generally there is no PLE generally does not occur, and if that is present, then the site of obstruction can be at ophthalmic artery. Risk factors in all retinal vascular occlusions, basically CRAO as well as CRVO. Older age, male gender, smoking, hypertension, obesity, diabetes, hyperlipidemia, cardiovascular disease, and coagulopathy. So, pathophysiology in CRAO, central retinal artery supplies the inner retina. Occlusion of retinal artery results in ischemia of the inner retina. When inner retina is damaged, it first becomes very edematous, and over time the edema resolves and inner retina atrophies. In central retinal artery occlusion, outer retina is perfused by choroidal circulation, and some inner retinal tissue may survive. Thus, some vision is preserved. That is why there is never no PL in CRAO. And in contrast, ophthalmic artery occlusion results in ischemia of both inner as well as outer retina, resulting in generally no light perception. Now, in OCT, we can see that in central retinal artery occlusion, the area marked in yellow signifies the inner retina, and the inner retina becomes edematous, as evidenced by hyperreflectivity of the inner layers. Vision usually between 20/200 and hand motion. RAPD may be present. Early in the course, the fundus may appear normal, and later it develops a cherry red spot. Cherry red spot is due to opacification of the nerve fiber layer as it becomes edematous. And fovea appears bright red because in fovea there is no overlying nerve fiber. So this finding may take hours to develop, and the edema is associated with the worst visual prognosis. Retinal blood vessels show and the other characteristic feature is box carrying. That is, retinal blood vessels show segmental blood flow. It is best appreciated on slit lamp, and after a course of 1 week, the vessels will reperfuse. Laboratory tests in patients over the age of 50 who have symptoms of giant cell arteritis, then we have to perform ESR, CRP, complete blood count, and platelets. Patients younger than 50 who are likely to have hypercoagulable states, they should undergo hypercoagulable workup like antiphospholipid antibody, autoimmune conditions, workup for autoimmune conditions, inflammatory disorders, and other hypercoagulable states. In a young patient with multiple or recurrent BRAOs, Susac syndrome should be considered. Older individuals, atherosclerosis and embolia are likely to be the cause. Evaluation of heart and echocardiography for determining cardiac function and abnormality of valves, echocardiograms and heart monitoring for rhythm defects, and carotid artery stenosis should be evaluated with carotid ultrasound. Differential diagnosis, again, PRAO, it can be ophthalmic artery occlusion, carbon monoxide poisoning, and ocular ischemic syndrome. Ocular ischemic syndrome presents with transient symptoms of visual loss. There can be conjunctival injection, neovascularization of anterior and posterior segment, inflammation in the anterior chamber of vitritis, optic nerve edema, and carotid disease is the most common cause. Medical therapy, retinal artery occlusion is an emergency. Patient should be referred to nearest stroke center for immediate further management. Recent studies show that high risk of cerebrovascular event in the ensuing days, so it is to be treated as on an emergent basis. Then in an Eagle study, the role of tissue plasminogen activator was evaluated for comparing, which was a randomized control trial comparing intraarterial fibrinolysis to placebo. Study did not recommend intraarterial TPA for acute CRAO because significant symptomatic intracranial hemorrhage was there without any evidence of visual benefit. Then the next management is ocular massage, conservative method to theoretically causes emboli to travel distally to reduce area of ischemia. Then similarly, anterior chamber paracentesis can be performed by removing 0.1 to 0.4 ml of aqueous with 27 or 30 gauge needle. Then IOP can be controlled with medically with eye drops. Then carbon dioxide is thought to propose induced vasodilatation. So inhalation of carbogen is also another alternative, which is a mixture of 95% oxygen and 5% carbon dioxide. And alternative oxygen mask can be used to increase the perfusion. So the next cause is retinal venous occlusion, CRVO or BRVO. In CRVO, the thrombus occurs at the central retinal vein near the lamina fibrosa. In BRVO, arterial occlusion of the vein at the AV crossing causes turbulence. And diagnosis is based on retinal examination findings, that is intraarterial hemorrhages, dilated veins, cotton wool spots. As in CRVO, it is described as blood and thunder appearance. And macular edema can also be present. In addition, it is important to perform undilated slit lamp anterior examination with gonioscopy to look for neovascularization of the angle prior to performing a dilated fundus examination on next visit. So above picture signifies the CRVO. In their picture, we can see superior temporal arterial STBRVO. And these are the cotton wool spots. These are the dot blot hemorrhages and flame-shaped hemorrhages. So imaging modalities, fluorescein angiography is useful for determining degree of ischemia. It should be performed generally after the hemorrhage is resolved so that we can better visualize the retina and the vasculature. And to allow good visualization of capillaries. And OCT is useful for monitoring the macular edema. So here we can see the fundus photograph of non-ischemic CRVO showing mild dilatation and tortuosity of the veins and scattered superficial and deep intraretinal hemorrhages. Then in the initial phase of the angiogram, there is no filling seen even at 30 seconds, and there's a marked delay in the filling of the veins. And then as the angiogram progresses, the fluorescein dye fills the veins completely. Tortuosity of the venules is well made out. And in the later stages, we can see extensive staining of the vessel wall throughout the macula because of the stasis in the veins. In ischemic CRVO also, we can see that the area of capillary non-perfusion is more than 10 disc diameters. It is extensive capillary non-perfusion as evidenced by these hypoperfusion CNP areas. And parafoveal capillary network is also affected. And in the later scans, as the angiogram progresses, we can see increased staining of the disc and the walls of the veins. In BRVO, in the early frames, we can see on FA large area of capillary non-perfusion distal to the site of occlusion. So here there's a site of occlusion, and here there's hypoperfused area. The dark area is signifies the CNP areas. BRVO is labeled as ischemic if it is CNP areas more than 5 disc diameters, whereas in CRVO it is more than 10 disc diameters. And in the sequelae, in BRVO, we can see NVs at the side as seen as the point of leak here. So in the late phase. And next is the macular edema. In early phase of the angiogram, we can see hypoperfusion, and in late phase, there is a hyperfluorescence indicating pooling because of hyperpermeability of the vessels. So here we can see this fuzzy appearance. It is because of the pooling and leakage. On OCT, in vein occlusions, we can see that there is a cystoid macular edema is present, and this is a sign in which we inject anti-VEGF for such patients. But the point to be noted is we have to look for also if there is any ISOS junction interruption. So in such cases, even if the edema will resolve, the patient can have less vision despite anatomical improvement. In management, first line is again, as I have discussed, anti-VEGF. Then the various anti-VEGF agents are ranibizumab, bevacizumab, and bevacizumab, and aflibercept. Ranibizumab, the studies were Bravo and Cruz, and for aflibercept, they were Galileo, Copernicus, and Vibrant. These were the studies for the use of these agents for treatment of macular edema, respective vein occlusions. Significant gains in visual acuity have been demonstrated. Bevacizumab, bevacizumab Percept have FDA approval, whereas bevacizumab is used often. And other modality is steroid implant, that is dexamethasone implant, which is also FDA approved for macular edema in CRVO and BRVO. It is generally second line for eyes with chronic edema that is poorly responsive to anti-VEGF injections. Follow-up, ischemic retinal vein occlusions cause iris and retinal neovascularization in addition to macular edema, and therefore it is important to monitor the undilated iris and angle examination, followed by dilated fundus examination on periodic basis. PRVO eyes should be examined monthly for at least 6 months. The risk is highest for development of rubeosis within the first 90 days, and then it decreases through next 6 months. Risk may be delayed if the patient has received anti-VEGF injections, and therefore if the risk decreases, we can later discontinue anti-VEGF therapy after watching the patient closely. Next modality is laser. So the two studies, landmark studies in use of laser were CVOS and BVOS. The CVOS study supported use of PRP for iris neovascularization, but did not support grid photocoagulation for macular edema. Whereas BVOS study supported use of grid laser for edema, and in addition also supported sectoral panretinal photocoagulation. So CVOS did not approve the grid laser, whereas BVOS approved the grid laser for edema. And the third cause is vitreous hemorrhage. Vitreous hemorrhage, often there is rapid onset of painless vision and can be substantial. Diagnosis is straightforward, but by either fundoscopic examination or ultrasonography, we can determine the underlying etiology. The three most important causes are proliferated diabetic retinopathy, posterior vitreous detachment with or without retinal tear, and ocular trauma. The less common causes are vein occlusion, vasculitis, proliferative sickle cell retinopathy, retinal arterial microaneurysm, or any choroidal lesions causing breakthrough bleed into the vitreous. So there are two basic mechanisms: rupture of normal blood vessels through mechanical force or hemorrhage from pathological structures. So as I have described, it can be either injury, closed globe with blunt trauma or open globe, and acute PVD. So PVD, vitreous hemorrhage in the setting of acute PVD associated with a retinal tear or break in 70 to 95% cases. And therefore, if the peripheral fundus is visualized, then we have to carefully locate the break, because generally it is associated with the retinal tear. And hemorrhage through pathological structures, it can be either because of any rupture of retinal neovascularization or macroaneurysm, or it can be choroidal tumor or choroidal neovascularization causing breakthrough bleed, that is as seen in age-related macular degeneration. Treatment, if the retina can be adequately visualized and the etiology of vitreous hemorrhage can be determined, then we can attempt for neovascularization from PDR, we can attempt panretinal photocoagulation, that is PRP, or we can give intravitreal injections, anti-VEGF injections, depending upon the state of neovascularization. If the neovascularization is raised and there is a surrounding fibrosis in that neovascularization, we generally do not prefer anti-VEGF agents because it can cause traction. So in such cases, first we perform the laser. And if the NVs are flat, then we can perform anti-VEGF injections followed by the PRP. Retina cannot be adequately visualized. We use preoperative anti-VEGF agent for 3 to 4 days, and provided on B scan, we can see that there is any traction on the retina underneath the vitreous hemorrhage, and then we can go for plasma vitrectomy. Because this preoperative anti-VEGF can help in regression of neovascular membranes, and also which can help in reducing both intra and post-operative bleeding and better dissection of tissue planes for the traction. In case of open globe injury with vitreous hemorrhage, but without intraocular foreign body, most surgeons generally perform the eye wall surgery first, and then vitreous hemorrhage is treated as a second procedure. The fourth disease is optic neuritis. As a cause of now we have seen the painless causes three. Now we are moving towards the painful sudden loss of vision. The first of them is the optic neuritis. It is multifactorial. It can be either autoimmune with a viral trigger like HSV or BZV. It can be inflammatory or demyelination. Then general pathology is it is immune-mediated inflammatory demyelination of the optic nerve. The myelin undergoes destruction, causing the axons to poorly conduct impulses. The axons themselves become damaged, and thus retinal ganglion cells axons often become damaged. Pathophysiology is that after myelin destruction occurs, ganglion cell axons start to degenerate. The monocytes localize along the blood vessels, and the macrophages follow them to remove the myelin. Then, in their place, astrocytes begin to proliferate, resulting in deposition of glial tissue. And this glial tissue is the one which we see on the MRI scan. That is, gliotic sclerotic areas become multiple throughout the brain and spinal cord, and hence it is termed as multiple sclerosis. So it is just proliferation of the astrocytes, which takes the position of the retinal ganglion cells which have degenerated. Risk factor male to male ratio is 3:2, so more common in females. In young age group, 20 to 45 year olds, there is a prodromal flu-like illness which accompanies the event, but does not usually always occur. And patients with multiple sclerosis often have optic neuritis up to 75% of the patients. In addition, autopsies of the multiple sclerosis patients show up to 90% of optic nerve involvement. So, presenting features in symptoms, we can see prodromal viral illness, acute vision loss, which tends to worsen over days and then slowly plateaus around 2 weeks prior to improvement. There can be discomfort of the eyes with eye movement, mild to severe. Patient can see flashes of light, which is called as phosphenes. Then there is Uthoff and Pulfrich phenomenon. Uthoff phenomenon, the patient vision becomes blurry when body temperature rises, either by exercise or bathing in hot water. Pulfrich phenomenon is altered perception of the motion, and color vision is washed out. There is diminution of color vision. In science, we can see decreased visual acuity, then red desaturation, decreased contrast or bright sense, then RAPD can be seen unless both eyes are affected or RAPD was priorly present in the contralateral eye. Then any nerve fiber layer or central scotoma on Amsler's grid and on confrontation visual fields. And typically the fundus can be normal, but optic disc edema can be seen in up to 35% cases. Thus, important point to note is that lack of optic disc edema is the rule rather than exception for optic neuritis. And we can also see pars planitis and we can see periphlebitis. So in diagnostic procedure, mostly we have to rule out any retinal nerve fiber layer thinning. So we have to perform OCT for glaucoma, like OCT for retinal nerve fiber layer thickness. It can quantify the onset of optic disc pallor, which ensues 6 to 8 weeks post the onset of optic neuritis. So it is an early marker. Then optic atrophy, which is subtle on generally on biomicroscopy, which can be easily picked up using OCT. And also in retrobulbar optic neuritis, OCT may be initially normal, and later as the macular ganglion cell loss occurs, then downstream there can be decrease in the retinal nerve fiber layer. Then visual fields, which can be either confrontation or by automation. The visual field pattern is generally not particularly helpful because it can be of various patterns, either diffuse, superior, altitudinal, inferior, three-quadrant, quadrant, or centrocecal. So there is no specific pattern to diagnose on visual field. Any of them can occur. Then also in VEPs, there will be delayed response on pattern evoked potential, and fluorescein angiography can be used to perform rule out true optic nerve edema if DD like LHON or other non-MS etiologies are suspect. Then most important investigation is MRI brain. So all patients with suspected optic neuritis should have a fat suppressed contrast enhanced MRI at the presentation. Main indication of MRI is derived from its prognostic value in presence of future development of MS. MRI is far superior to CT scan, and the criteria is that on MRI, one or more T2 hyperintense lesions in the periventricular, cortical, or juxtacorticular, infratentorial, or spinal cord regions is demonstrative of dissemination. So this is the criteria in the various forms of multiple sclerosis, neuromyelitis optica, then oligodendrocyte associated and multiple sclerosis. The distribution of lesions, it is generally unilateral in multiple sclerosis. Segment involvement in neuromyelitis optica, it can be intracranial, chiasmal, or optic tract. In MOG, it can be retrovulvar, and in multiple sclerosis, it can be retrovulvar and canalicular. Length of the lesion in multiple sclerosis is generally short and segmental, whereas in other two forms, it is longitudinal and extensive. Degree of optic nerve swelling is severe in MOG associated. Location of post-contrast enhancement, generally here it is optic nerve and perineural, whereas otherwise it is optic nerve. Presence of brain MRI lesions commonly observed in neuromyelitis optica, whereas it is infrequent in MOG. And characteristic brain lesions. Differential diagnosis, again, it can be neuromyelitis optica, MOG, then central retinal vein occlusion, diabetic papillopathy, LHON, radiation-induced optic atrophy. So management, the ONTT was the landmark multicenter clinical trial for the treatment of multiple sclerosis. And the outcomes were that IV steroid treated patients recovered faster within the first 4 to 6 weeks post onset. And oral steroids in conventional doses alone are contraindicated for acute optic neuritis because of high rate of recurrence of optic neuritis. So generally, what we do is we give 1 gram IVMP for the first 3 days, and then 1 milligram per kg body weight for the next 11 days. So treatment, same as I have described. Low dose 60 milligram per kg oral steroids are contraindicated in patients who have acute optic neuritis, especially in patients that carry a diagnosis of multiple sclerosis. Depending on etiology and response to therapy, we can either add plasma exchange or IV immunoglobulin therapy. And in follow-up, visual acuity testing is important. Visual field testing, if possible, should be done at presentation 3, 6, and 12 months, and OCT of OCT RNFL at onset and 6 to 8 weeks visit, and at 6-month follow-up for quantification of the optic atrophy.
Okay, Amog, what are the indications for doing investigation for NMO antibodies and MOG?
So depending upon the MRI, the lesions, based on that we can suspect the likely etiology. And
No, when do you investigate? Like a patient comes with optic neuritis, do you advise the antibodies for all patients?
no, not all patients, sir. First, MRI is advised, and then based on that, what is the location and the various characteristics of the MRI, then we can further prescribe.
Suppose optic nerve is involved, it's showing retrovulvar optic neuritis. Then previous slide. And what are the investigations that you advise?
Sir, OCT RNFL first. As ophthalmologists, first we'll do OCT RNFL for RNFL thinning to localize that. And VEP we can carry out. And then we can go for MRI.
So in MRI, what are you looking for?
We are looking for T2 hyperintense lesions in the periventricular, cortical, juxtacorticular, and spinal cord lesion.
Okay, and you do brain and spine also for all patients?
Yes.
What is your primary aim for looking for advising MRI brain?
Because primarily we have to rule out multiple sclerosis in the optic neuritis patients.
Okay.
Systemic.
First thing is to rule out multiple sclerosis because that is commonest disease to be associated with optic neuritis. Okay. And second, you go for other antibodies test, etc. If it is a atypical optic neuritis to begin with, or patient has other neurological symptoms to start. Okay.
Yes.
Okay. Go ahead.
Next, this thing disease is acute congestive glaucoma as a painful sudden loss of vision. Angle closure glaucoma is the major cause of blindness worldwide. It generally has familial tendency associated with increasing age and hyperopia. Risk factors are short axial length, shallow ACD, family history of angle closure, advancing age, female gender, and
Acute congestive glaucoma, anyway, we'll cover it in glaucoma part. So you can skip this. I think we already had class on this.
acute iridocyclitis.
Yeah. Okay. Continue with this.
So the anterior part of uveal tract basically involves the iris and the ciliary body, which are the mainly primarily affected by inflammation. Inflammatory cells are seen in the anterior uvus, in the anterior chamber in the form of iritis, and sometimes behind the lens in the anterior vitreous, anterior hyaloid face in the form of iridocyclitis. And acute disease is characterized by sudden onset, diminution of vision. Symptoms typically develop rapidly and over a few days, but it is short-lived, that is of limited duration. If the therapy can be tapered and inflammation does not recur for at least 3 months of treatment, then the disease is classified as acute but of limited duration. Whereas if in contrast, if in chronic disease, the inflammation will recur after the medication is tapered or stopped. So presenting features, symptoms can be redness, pain, sensitivity to light, that is photophobia, and vision loss can be variable. The signs will be anterior chamber cells and flare, keratic precipitates, hypopyon, fibrin, then iris nodules, and posterior synechia. So this is the sun grading for sun classification for AC cells and flare. It is 1 by 1 mm slit is performed in oblique light slit lamp oblique illumination of 60 degrees projected onto the iris, and then we can in every this thing we can see that the grading 0 is less than 1 cell, 0.5 plus is 1 to 5, 1 plus is 6 to 15, 2 plus 16 to 25, 3 plus 25, 26 to 50, and 4 plus more than 50. Similarly, flare can be graded into faint, moderate, marked, and intense. Intense is called as when there is fibrin present in the aqueous or it is plastic aqueous. Hypopyon also classifies into the grade 4. Then differential diagnosis can be either infectious, inflammatory, malignant, or other. Infectious, we have to rule out syphilis, tuberculosis, viral etiologies like HSV, CMV, VZV, rubella, and toxoplasmosis. And inflammatory, most common anterior uveitis is caused by HLA-B27 associated. And other causes can be sarcoidosis, psoriatic arthritis, tubulointerstitial nephritis, uveitis, or TINU, and inflammatory bowel disease. Malignancy to be ruled out is lymphoma and retinoblastoma, and other can be either idiopathic or drug induced. So mainstay of management of acute anterior uveitis is topical. Usually a topical corticosteroid such as prednisolone acetate 1% is used as an anti-inflammatory, and combination with a mydriatic cycloplegic drop, either 1% atropine sulfate or 2% homatropine bromide, which will help in reducing the pain and prevent or release the posterior synechia formation. Infectious forms of acute anterior uveitis after diagnosis on the clinical tests, blood investigations, then we can start the antimicrobial agents like any antiviral or antimicrobial. Severe acute anterior uveitis, if it is present, then we can either use periocular or intravitreal steroids or oral steroids. Periocular injection of triamcinolone acetonide 1 ml 40 milligram, or oral therapy like prednisolone 1 milligram per kg body weight with weekly taper by 10 milligrams. And complications of inflammation such as elevated intraocular pressure is to be managed by topical systemic anti-glaucoma medications. And uveitic cystoid macular edema, then we can generally perform intravitreal triamcinolone acetonide 0.1 ml, 4 milligram can be used. And there's no specific surgical treatment for uveitis. If any surgery is to be performed like cataract surgery, it should be delayed typically for 3 months till all the inflammation is resolved. We can perform the cataract.
Okay, you can summarize the congestive glaucoma also. I think that will complete this.
So in angle closure glaucoma, there is increased intraocular pressure, which is caused by impaired outflow facility secondary to appositional or synachial closure. It can be either primary or secondary. In primary, the underlying mechanism is pupillary block, and in secondary, the mechanism is either push or pull of the iris, either forward, push of the iris forward or pull to contact with the trabecular meshwork. And both types of angle closure glaucoma may cause acute dramatic attacks or chronic asymptomatic disease. So these are the various terminologies which we encounter: PACS, PAC, and PACG. In PACS, the angle is anatomically narrow. The eye in which the anterior chamber angle recess has an abnormally narrow angular width. Peripheral iris is located close to but not touching the PTM. There is no pass, IOP, optic nerve, and visual field. Everything is normal, but just there is appositional contact. In primary angle closure, angle is anatomically narrow, and then there is presence of pass, elevated IOP, iris swirling or sectoral atrophy, and excessive pigment deposition on trabecular surface. But there is no glaucomatous damage to the optic nerve. And in PACG, all of the above plus there is damage to the optic nerve, which can be detected on the visual fields. Secondary angle closure, it is either cause pathological entities result in this, such as neovascularization or uveitis, resulting in secondary angle closure. So these are the various causes for the various iris push and pull. In push mechanism, there can be relative pupillary block, then plateau iris configuration, aqueous misdirection, ciliary body swelling or inflammation or cysts, choroidal swelling, effusion or detachment, then contraction of retrolental tissue, as is seen in ROP, anteriorly displaced lens or encircling retinal bands or buckles. And in iris pull forward, it can be either contraction of inflammatory membranes or fibrovascular tissue, then ice syndrome, fibrous ingrowth, epithelial downgrowth, or iris incarceration in traumatic or surgical wound. So diagnostic modality, the gold standard is gonioscopy. It can be either dynamic or compression or indentation gonioscopy. Differentiate appositional closure from the synachial closure. Important to note is that it should be performed in the dark room because even a slight amount of light can cause the iris to constrict and it can falsely open the angle. And occludable angles are typically described as eyes in which the posterior pigmented trabecular meshwork is seen in less than 90 degrees of the angle circumference, or the angle width is less than 20 degrees. And the two imaging methods are ultrasound biomicroscopy and ASOCT. In UBM, there is high frequency B scan ultrasound, which provides high resolution cross sectional images of the anterior segment uh, anterior to the of the eyes, anterior to the vitreous. And because it uses sound, it can pass through opaque structures and visualize the structures hidden from direct clinical examination, such as the ciliary body in particular. And it is particularly helpful for plateau iris syndrome and ciliary body pathology. Whereas ASOCT, advantages of ASOCT over the UBM is that it is a non-contact exam, and the patient can be imaged in upright position, avoiding positional lens changes, and all four quadrants of the angle can be scanned at once. And it is compared to UBM, it is unable to image structures posterior to the iris plane. So it's how the angle appears in ASOCT, the various angle structures which can be visualized. And this is open versus closed. We can see the iris configuration and how it is coming forwards and obstructing the angle. And again, UBM versus ASOCT I have mentioned. In management, firstly, we can start with topical medications like beta blockers, alpha agonists, carbonic anhydrase inhibitors. Myotics, generally 2% pilocarpine can help in breaking early angle closure attack, but it is ineffective if the iris is already ischemic. And higher concentration of myotics like 4% should be avoided because it can forward displace the iris lens diaphragm. And prostaglandin analogs is unreliable because slow onset of action. Hyperosmolar agents can be used for clearing the corneal edema like 5% sodium chloride, and prednisolone acetate decreases the inflammation. Systemic carbonic anhydrase inhibitors, oral acetazolamide maximum IAP reduction is reached in 2 to 4 hours and lasts up to 6 to 8 hours. If the patient is having vomiting episodes, then we can inject intravitreous also. Intravenous, and peak effect noted by 10 to 15 minutes. Regular acetazolamide is preferred over sustained release because it is a quicker onset of action. Then various osmotic agents can also be tried like mannitol, which can decrease IOP by 30 mm or more within 30 minutes of administration. Dose is typically 0.5 to 1.5 gram per kg body weight as a 15 or 20% solution. It is delivered in the speed of 3 to 5 ml per minute. Then important points to be ruled out is that the patient should not have any cardiac or renal or pulmonary lesions. Then rapid reduction of cerebral volume may result in subdural hematomas, and hence such patients should be always monitored in a hospital setting. Then in other osmotic agents are oral osmotic agents like glycerin or isosorbide. Glycerin is avoided in diabetics because it increases the caloric load, whereas isosorbide can be given because it does not get metabolized. Then the definitive management is laser PI. The role of laser PI is to relieve the pupillary block. It is performed with standard frequency NDI laser, is 1064 nanometers. And with the help of Abraham lens, we can puncture the iris at its thinnest point, that is at the crypt, generally in the superior half of the iris, in the superior half of the angle at our 10 o'clock or 2 o'clock. And the end point is like when we hit the crypt, this sudden gush of the aqueous and the iris diaphragm moves back. So that is the a sign that PI is complete. Generally, power used is 1 to 6 millijoules, spot size 50 to 70 microns, number of pulses or burst 1 to 3. And this is the technique of performing.
Okay, in where IV mannitol cannot be given, you have spoken about glycerol and isosorbide mononitrate. Which of this is commercially available, and what is its this thing brand name which is available? Okay, you find it out. Okay.
Yes. Yes.
And report to us, because glycerol in between we tried to find out, but it was not available easily. So you find out about isosorbide.
Yes.
Okay. Any other questions? Okay. Okay, then we'll finish the. Okay. Thank you.